Hey, good morning, everybody. I'm gonna give a couple of minutes to wait for everyone to join this collaborative kickoff for our CalAIM Reentry Initiative Learning Collaborative office hours. So I'll give about 1 or 2 more minutes for everyone to join. So good morning, everybody. Welcome, welcome. I hope all of you had an opportunity to take away some things from our California Advancing and Innovative Medi-Cal Reentry Initiative Learning Collaborative that we had. This is the office hours for our kickoff session. Next slide, please. We plan on starting today with a few key takeaways from our first session. So we're going to do a mural board. This activity should show up. I believe it's going to show up in the chat, and we're going to get it going right away. Oh, there it goes right there. Sorry. So during last week's Learning Collaborative kickoff meeting, we used a mirror board to solicit feedback from the top 10 policy operational issues that we had, things that were identified by correctional facility partners. So thank you again for your thoughtful comments as we continue to phase through this whole process together. Your feedback will be, it's invaluable.
Panic.
Oop, hi, Gail. Hi, good morning. Sorry. Your feedback is invaluable as we prepare for the future webinars and learning collaboratives during this series. We're resending the links to the board, so it should be in the chat coming up in just a second. Once those show in the chat, we'll use that board for today's chat if anyone was not able to contribute to last week's collaborative session that we had. We put together an initial non-exhaustive, list of key takeaways from comments, questions, and anything that was submitted in last week's mirror board. There are many questions submitted, and we're working to integrate those together queue that we can send out as a document to everybody, and also be posted and updated throughout the Learning Collaborative series to our website. Next slide, please. Or we're going to do that. That should pop up now. You have the link in the chat. Sorry. All right. So most of the things that popped up for our mural board last week activity were stakeholder requested additional details and roles, responsibilities, and key activities for care manage warm handoffs, the expectation for sharing reentry plans, reentry care plans. Stakeholders sought clarification for expectations of behavioral health linkage, including communication with data sharing expectations between key partners, the CFs, the BHAs, the MCPs, as well as guidance on billing and behavioral linkage services. Stakeholders expressed a desire for more information on how JI codes activation timelines will affect the 90-day calculations and billing, and requested scenarios on pausing, resetting, restarting for the 90-day clock. Stakeholders also requested billing guidance focused on which entities can bill for which services, and certain services, and they sought clarification on how CalAIM interacts within the MCIP and MSIP. Stakeholders emphasized the importance on soliciting input on policies from a diverse array of implementing partners, including community-based organizations, reentry partners, providers, and behavioral health agencies and correctional partners. So that was what came from the mural board takeaways last session, and we're going to try and get more moving forward with each collaboration that we have. Next slide, please. All right, so we're going to just have a reminder, because this came up a lot in our Q&As and a lot from stakeholders when they were sending questions in to us about the correctional facility and behavioral health agency readiness assessment expectations. Next slide. From the correctional facility readiness expectation requirements, which is the pre-release services, correctional facilities are required to submit a readiness assessment application at least 6 months prior to requesting their go-live date. This is to demonstrate the readiness to provide pre-release services and behavioral health links. Readiness assessments should be conducted on a quarterly basis, although some of the timelines have changed a little bit, but we want to collect those on a quarterly basis and focus on the 5 key areas. Readiness decisions and approvals for go live will be made on individual facility basis. So on that level, not on a county level. So just keep that in mind when submitting your readiness assessment application moving forward. Next slide, please. And also something to remember is we have a checklist, a go live checklist. The links here aren't live for you to click on, but we will submit it with the presentation today so you guys can have it. You should have it already, but if you don't, you'll receive this presentation so that you can click the links and take you straight to them. Our checklist items include enroll for provider, completing items with new provider checklists, and completing JI screening portal, the 90-day pre-release trainings. Complete outstanding readiness activities if received for conditional approval. Conditional approval guidelines are still being developed, so you'll be receiving those as soon as our leadership team completes them. So hopefully that helps you a little bit with the go live for correctional facilities. I'm going to pass this off to Megan Shandell to go over the behavioral health linkages. Thank you so much for your time.
Hello, everybody. So just a refresher and a reminder, the readiness assessments for behavioral health agencies were due back in April. DHCS has received the readiness assessments for all BH agencies. As a reminder, all counties must go live with behavioral health links on October 1st of this year. County behavioral health agencies must also enroll as a fee-for-service provider, complete outstanding readiness activities, and complete the trainings. And those are linked on this slide as well. Next slide, please. So DHCS has received many questions regarding the rationale for behavioral health agency go live timeline. We wanted to reiterate the expectations for counties where correctional facilities are not live with pre-release services and where they are live. So if the county correctional facility is not live with pre-release services, the behavioral health agency, if the county of responsibility, should receive the behavioral health links from other counties or state entities that are live with pre-release services. The details on that area of the policy are contained in section 11.4 of the policy and operational guide. The county behavioral health agencies must also cover medically necessary post-release specialty mental health services or DMC ODS services to formerly incarcerated Medi-Cal members that meet criteria. Must also ensure adequacy of behavioral health network providers to meet the need for reentry for post-release. And then must also collaborate with county correctional facilities to plan for the county go live of pre-release services. If the correctional facility is live with pre-release services, the behavioral health agency should, if they are the county of responsibility, receive the behavioral health link from the county correctional facility. Again, that's in 11.4 of the policy and operations guide. The actions are detailed out there. Then you must also provide pre-release in-reach mental health or substance use disorder services as applicable, cover medically necessary post-release specialty mental health services or DMC ODS services to formerly incarcerated Medi-Cal members that meet criteria, ensure adequacy of behavioral health network providers to meet the need for reentry, both for in-reach and post-release, and then also collaborate with the county correctional facility to plan for county go live of pre-release services. And with that, I believe I'm handing it back over to Autumn.
All right, thanks, team. We wanted to use the rest of the time that we have set aside for today and for all of you who came to participate in today's office hours session to really have a time for open forum so that you can ask questions that are top of mind. In particular, these office hours sessions are meant to be a follow-up from the prior learning session. So typically focused on the content that was presented at the last session. So, of course, last time we talked about the JI program at large. We talked about provider enrollment, obtaining an NPI number, some of the requirements around the ordering, referring, and prescribing practitioners. But this is an opportunity for you to ask other questions as well. I'm just noting that there will be more in-depth sessions on topics related to the screening portal, claiming, billing and claiming and billing guidance, behavioral health services specifically, where we'll dive into questions around some of those components, warm handoff and ECM and all of that. So again, this is more of an opportunity for us to just have a dialogue with all of you. And you are welcome to ask us questions either as a follow-up from the prior session or something that's a burning question that you've been wanting to move forward in your preparations for the readiness review process or for implementation. So you can put your questions in the chat, but we also invite you to raise your hands and go ahead and interact. These are meant to be interactive sessions with us. I know that there's already a couple of slides about the materials and recordings. We do have the transcript from last week's meeting ready to go. We'll send out to all of the people that participated or registered for last week's session the materials via email today for the materials and the transcript of the recording so that you get like all of the backup information. We are also going to be posting the actual recording from last week's session along with the materials to the DHCS Justice Involved Resources page, as well as on our DHCS YouTube page. There will be a channel for like the content from this learning series, and it'll be posted on the DHCS YouTube page. So we're still working on posting the recording. That might take a few more days to get all of the information posted on our website, but we will be sending it out via email to all of those that registered and participated today. So we are, we know that there's a lot of questions in the chat. Let's go ahead and give folks a chance to raise your hand and ask us questions if you have them. So we'll take questions now, or we can start reading off questions from the chat. But wanted to just have this time for you all to be able to interact with us. So let's see. So you can use actually you can just unmute yourself. I guess is there a raise your hand feature?
This is Scott in Placer County. Sorry,
Hey, Scott.
I don't see a raise your hand feature on my side.
Oh,
so
yeah, maybe we don't have that one on this one, but yeah, go ahead, Scott.
I had a question around enrollment. You mentioned that.
Hey, Rose, how's it going?
Thank you. Go ahead.
We actually provide specialty mental health and DMC-ODS currently. Is enrollment to claim fee for service for pre-release enrollment, or does our current enrollments as a specialty mental health provider and DMC-ODS provider cover pre-release services?
Scott, what county entity are you with?
Placer County.
Yeah, I know. Which county entity are you part of the
Health and Human
behavioral health
Services.
agent? I'm sorry?
Health and Human Services.
Health and Human Services. So you all are like the county, Placer County Behavioral Health Agency, right? Like the mental health, like that entity is actually a plan entity, and so the way that works, in terms of reimbursement for especially mental health services and drug, medical, and organized delivery system, it's like a little bit different role. What we're talking about is enrolling as a provider entity, and so in our fee-for-service delivery system, and it is separate. We are looking at our existing enrollment, so there are many behavioral health providers that are enrolled in our PAVE system, in the drug medical system. We do not have our specialty mental health services providers enrolled through our PAVE system. So that is something that we're looking at a solution for, because as you know, like the counties operate as plan entities and bill through a separate mechanism through short dwell Medi-Cal. And so in order to get reimbursement for pre-release services, you either need to be enrolled as a fee-for-service provider in DHCS system, which we're working on a solution for, or you need to have a contract with an arrangement, because in this case, it would be probably more of an inter-county, interagency agreement, where you would be enrolled as the correctional facility. Now, if your Health and Human Services is also the delegated county entity that provides correctional healthcare services, then you would enroll as the exempt from licensure clinic for the correctional facility, and then the claims would just go through that enrollment. I know that's a little bit complicated of an answer. It's a little bit of a complicated of a question too, Scott, but hopefully that's clear. But please feel free to ask a follow-up question if you have follow-up questions about that.
Autumn, can I mention something that may make
Yeah.
it even more complicated? I think there is a division of services and how they're billed for county behavioral health when it comes to pre-release services and the county behavioral health agency catching a linkage. I believe that is paid through the regular short Doyle system. If we're talking about a pre-release service that is clinical consultation, behavioral health type of service, that's where the entity provider needs to be either, as Autumn mentioned, enrolled in Medi-Cal fee-for-service billing through CAMIS, or operating through a contract with the correctional facility and billing with the correctional facility's enrollment. Autumn, does that sound right? Anybody else?
Sounds right.
And then, of course, everything is billed through short Doyle as normal.
Okay, so somebody found the hands. Scott, hopefully that answered your question. Feel free to circle back if it didn't. We'll be happy to work with you one-on-one as well. Ron Klinger, for partnership, I see your hand.
Yeah, thanks, Autumn. A couple of questions, if I may. One is probably the simpler one for bundle 3. There seems to have been a little confusion for the community provider receiving the warm handoff. Would that be billed to managed care during the pre-release period? In other words, in the overlap, or do we need to have our providers sign up for PAVE as well for that?
All of the pre-release services are billed to through the fee-for-service delivery system. That's what's required as part of our 1115 waiver special terms and conditions. So we don't have any managed care billing while the individual is in custody. It's not until they are released into the community and the enrollment into the plan is effectuated that the plan would pay for those services directly. So providers of pre-release services billing the care management bundles while the individual is still incarcerated will need to be enrolled as fee-for-service providers.
And I think
or
we may
have a contract with a correctional facility.
That's
Okay.
what I was going to say.
Got it. Okay. So PAVE. My other question is, we, along with several other managed care plans, are beginning to build out data sharing agreements and data sharing processes as we wait to see what the portal. Now, I know we just have a couple of weeks before we'll get to see that portal, but I just wanted to see if you had any guidance or direction around that, because we know we have Yuba coming live for our plan, so we're trying to get something in place so we can begin this process. So if you have any guidance or direction around that, we'd appreciate it.
I will say that we are going to put out like a template MOU agreement in terms of roles and responsibilities. That'll be coming later though, so we don't see that as a prerequisite for go live. But we have heard that having a template and standardization would be helpful. So we are moving in that direction. Likely this spring is when, we'll be ready to share that. I think proceed in the meantime, and then, of course, unfortunately update as necessary. But if you could say more about why you're waiting for the portal piece specifically, then maybe we could also provide you a little bit more guidance there.
Sure. It's just the unknown. So I don't know if the portal will have the necessary information for us to initiate eligibility and create a TAR and such. It sounds like maybe it will not. It's more of a billing notification platform, but that's what I'm trying to avoid is duplicative processes, right? So if we're building this out because we have a go live in October, and waiting for the MOU template in the spring. We need something in the gap, right? So
Yes. So the portal, and I'm going to ask the team to back me up here. I see Sarah came on camera too. So what the portal will do is that will be the mechanism by which the correctional facility or county entity that's responsible will basically turn on the JI specific aid code by entering the screening data for the member into the portal. That's after, of course, they've already been enrolled in the Medi-Cal program. So that's activating their coverage during that pre-release period. It'll include the release date, and it'll kind of back end, let us know that that member is on the 90 days of pre-release services. There's also, so at that point, right, like the member may or may not have been previously enrolled in Medi-Cal. They may or may not have previously been enrolled in a plan, but in a Medi-Cal managed care plan, just for everybody's sake, but when the JI aid code is activated, we will also start the auto assignment process to get that member assigned to a post-release Medi-Cal plan so that we can do the notifications to the plans and the correctional facilities about which plan. So like in your case, right, that's a little bit more obvious if the member is releasing to the county, but I think, that's kind of the process of how that will work.
Can I add to that?
Yeah, please.
Thank you.
Please.
So no problem. So yeah, the portal is really going to be the mechanism in which that aid code is turned on. It kind of indicates, right, okay, this individual is within that period of time. So what happens prior to that is if an individual comes in with managed care enrollment, they're incarcerated longer than 28 days, we apply a benefit suspension to their Medi-Cal, which helps ensure that we're not paying anything while they're incarcerated. We're staying in compliance with the federal rules around doing so, with the exception of this program. So then once that aid code is turned on, as Autumn said, if they were not previously enrolled and put in hold, that enrollment will start, but they will also be put in hold status. We're not going to start capitation, anything until the release, the aid code is turned off. The JI aid code specifically is turned off. At that time, when that JI aid code is on and they are put into a plan or were already put into a plan, the JI aid code indicator will be, the JI indicator would be put on that 834 file as a heads up, this person is on JI, they're enrolled in your plan. We anticipate because of the JI being on, the aid code being on, that they're being prepared to release, so that way the plan has a heads up on them coming forward and can then begin that coordination. So really the portal is going to be the mechanism to communicate to the correctional facilities what plan the individual is enrolled in, whether it's on hold and that information. And it'll also, like Autumn said, it'll trigger a termination of the JI aid code at the reported release date so that they can then transition to their primary county Medi-Cal, go into the plan and be no longer in the JI program.
Thank you. One last follow-up, and then I promise I'll stop because I know other people are in line here. Does that mean that when the JI aid code is turned off, they will immediately have full code, not full code, but full scope eligibility with us? It won't be subject to the usual delay of 30 to 45 days?
So there's a lot of different scenarios that come into play, but it would be triggered by the county activating the benefits if they were suspended. So what we have in place is when we're suspending, it basically goes up to the date. The date the release is reported, they would be shown in our system, and on the 834 and all the other processes are triggered as fully enrolled, activated. We trigger the capitation, all of that begins. That's already been in place for our incarcerated population, so we're leveraging that. Now, what you're talking about, the 30 to 45 days, is if someone was not previously enrolled and that enrollment process needed to start. Now, ideally, if someone has that full 90 days, we will be able to get them enrolled pending in the system and it'll all play out. But if someone has a very short day or a turnaround time, there may be some delays in that. But ideally, we're hoping that the majority of the people will either go in with managed care already in place and just put it on hold for the duration of their incarceration, or be in the aid code long enough to trigger that enrollment. However, we do have policy that says if they're incarcerated less than 28 days, we do not need to suspend their benefits, because we do not want to impact that capitation for the period of time in which they're in the community.
Okay.
Ultimately,
Thank
we're
you. I
trying to
appreciate
close that gap as much as possible so that the member is full scope eligible and enrolled in a plan on the day of release to the extent possible.
Great, thank you, because I know some of our CBOs are concerned about floating that gap, so we appreciate that help. Yeah.
In the case where there is a gap, the bundle 5 can be billed as fee for service post-release.
Got
And
it.
so
Okay.
we've tried to set it up that way so that we can account for gaps in terms of getting the member started with the ECM provider immediately.
Perfect, and I appreciate that. That makes sense for bundle 5. And just to, sorry, Autumn, I want to just, because the way that the guidance on bundle 3 is written, it says that the community provider bills to managed care. So you're saying that's not accurate. It's actually going to be PAVE system for bundle 3, the warm handoff for both.
Ashley, Deli, or one of our bundle folks or Brian, can somebody respond there?
Can you clarify what guidance you're looking at that refers to billing?
The slides, the original slides that were shown when they introduced the bundle rates. For bundle 3, it says that this is the one bundle that can be billed twice. Once fee for service for the embedded provider handing off, and then once to MCP. So
I can clarify that. What is meant there is, and this gets a little more complicated, so I'm going to take my time.
Okay.
What is intended is that in some cases, a correctional facility, their embedded care manager staff may not be the best people who are most familiar with community-based services to sort of plan and set those services up upon release. So we're envisioning a scenario where they work hand in hand with the community-based ECM provider at the same time to set up some of those services that ECM provider knows more about, like housing or working with TARS with the managed care plan. The intention there is still that community-based ECM managed care plan contracted provider, they would still be billing fee for service during that time frame, just like it were an in-reach scenario and they were doing everything. So that's all that's intended. There is no managed care plan billing pre-release.
Until after release. Okay, thank you for the clarification. We'll get to work on getting all of our providers enrolled in PAVE.
Thank you. Cindy Walter. Cindy from Calaveras.
There you go. Hi. Sorry about that. I'm from a correctional facility. So my understanding is we're going to be doing billing directly with DHCS, not with the insurance companies. And as a correctional facility, we don't have any, we've never done any kind of billing, medical billing before. Is there a software system that would be preferable for us to use instead of, the ones that behavioral health uses and stuff, because that's meant to go straight to managed plans?
So I think maybe we can set up a call with you, but typically the billing is done, would be done through like an electronic health record that would generate the billing information. I think we have some information that's coming up in our billing and claiming training, and from a systems perspective on some of the technical direct instructions around the claiming pieces. You can also sign up for our Medi-Cal provider portal, and it'll give you there's lots of trainings and things that'll be available through the portal. But coming up in September, that's probably a training. And then I think we could work with you one-on-one, Cindy, to provide some support in terms of the system infrastructure that's needed to facilitate billing. But ultimately, the counties still use for the county billing, they still use similar types of software. It's just the claiming system is a bit different. But there's not one standard EHR that is required.
And
I would love that. If someone could do some one-on-one with me for that, I would appreciate that a lot.
yeah, Cindy, one other thing I'll mention is that developing this new capability for correctional facilities to be able to bill DHCS, Medi-Cal is one of the biggest lifts we know that correctional facilities have to do. And our expectation is that correctional facilities are applying for PATH funding to fund a lot of those changes and potentially to hire consultants as needed to help them figure out what they need to do. That's certainly an allowable expenditure for PATH funding. And I know a lot of other counties have done that to help them through the process.
Well,
There's
it seems to be a big push to go towards a third party to do it for us, but we're a small facility, so we'd like to try and do it ourselves if possible.
I mean, being a small facility actually would probably support the recommendation to use a third-party billing entity because they already know all of the Medi-Cal claiming rules and all of that. But again, we can work with you and try to get, you pointed in the right direction. And further have conversations about what's best for Calaveras County.
Thank you.
You're welcome. We'll make a note to follow up with you. Heather Luer.
Hello, thank you. I had a question regarding the short Doyle Medi-Cal billing. The last we have heard is that the billing guidance has not come out yet, and it was supposed to have come out already. And I'm just wondering if there's an update.
Team, I know that some billing guidance is coming out. I don't know that it's the behavioral health piece, so can you provide an update there?
Hi, this is Ashley. So there's going to be additional guidance coming out for fee-for-service billing. I'm not entirely sure about the short Doyle piece. However, what I can do is I will provide a contact in the chat if you have specific questions about billing for short Doyle that you can reach out to. But yes.
Part of the issue is kind of what I flagged earlier with the making sure all of the behavioral health providers are enrolled through our fee-for-service delivery system for the claiming for behavioral health services that are provided pre-release. The only thing that can be claimed through short Doyle is the county entity receiving the link. Everything else needs to be, like if you're doing clinical consultation or MAT services in the correctional facility or any of those other pieces, that needs to be billed through our fee-for-service delivery system. And so the guidance will kind of cover those pieces, but we're taking basically the same, like the codes that you would normally bill and building that into our fee-for-service delivery system.
Okay, I'm with County Behavioral Health, with San Bernardino County Behavioral Health. And so that's why we were looking, because part of our readiness assessment was saying that we would be ready by 10/1 if this codes were available by July 1, because we don't know, we have to make sure that all the billing codes are set up in our system in order to bill, to receive the links.
Heather, I just wanted to add something. I apologize, just so you don't miss it, because our chat is getting quite large. But I do recommend make sure that you sign up for that Medi-Cal subscription service, because that's going to alert you when articles are published for JI. And I've also provided the link where all the current JI articles are published, and those will continue to come out. So definitely recommend referencing those as well.
Thank you.
Just so you're in the loop on everything. Yeah.
Yeah, and I'll make sure I've signed up for some of them, so I think I'm on it, but I'll double check to make sure I'm on that one. And then you were saying something about ECM billing fee for service if they are working alongside an embedded provider. And I'm also a county behavioral health ECM provider. So we would not, as county behavioral health, enroll in PAVE, is my understanding. I don't think we enroll in PAVE, correct?
Yes, if you're providing services to individuals while they're still incarcerated, the county plan operated provider would need to be an enrolled entity to be able to claim the fee-for-service services provided while the individual is in custody.
For anything other than the warm handoff linkage. So for care management services, for billing those bundles, those are all PAVE enrollment fee for service, or for entities that don't have an enrollment pathway, I believe the option is to contract with the correctional facility to sort of act as an embedded provider.
Correct. And bill through the correctional facility MPI. Or the correctional facility would bill and then pay you against the contract.
Right, yeah, and those we all have set up. It was that ECM could bill this one piece I hadn't really focused in on too much. So that is good to know. Thank you so much.
B?
Did you say Debbie?
Yeah.
Okay,
Debbie
great.
Sprague.
Thanks so much. My name is Debbie Sprague with the Alameda Alliance for Health. I have a question on the data sharing. So in the DSAG, it states that correctional facilities are listed as HIPAA covered entities. So my question is it all correctional facilities are covered entities throughout the state? And also, or is it the clinic within the facility that is a covered entity, a HIPAA covered entity?
So it'd be the exempt from licensure clinic as a Medi-Cal enrolled provider would be a HIPAA covered entity.
There's a little, I had the same question earlier. There's a little asterisk after they say that they're a covered entity. And then if you read the information in the footnote related to that, it says if they're doing Medi-Cal billing and or, it's not as simple as that initial statement that they're a covered entity. And if I have that wrong, somebody from DHCS, please correct me.
That's in the data sharing authorization guidance.
Yeah, she referenced the DSAG and someone from our correctional facilities, highlighted that and sent it to me and said, oh, we're covered. And I said, well, there's a little asterisk there. And if you read the footnote, it's not quite that simple.
Thank you, Michelle.
Yeah. Pulling it up. Do you know what page it's on?
I'm sorry, I don't. And it would depend on which guidance you're looking into.
Well, I'm looking at the data sharing authorization guidance, but
for JI reentry or just overall.
What page it's on. Take a moment.
If you want to drop the link to the document in the chat, then we can take a look at that footnote.
Yeah, that Autumn, this is Brian from DHCS. That did sort of track with my recollection of when I looked through that language. It seemed to be one of those areas where we were indicating it was likely, but DHCS was reluctant to make a final legal determination about that. So we were more providing the criteria of how that criteria works than saying for sure.
I think though, as an enrolled provider, like for the exempt from licensure clinic, right? So maybe I don't know if that I maybe not totally understand the nuance of the question.
Then what I'm actually asking for is who can we share information with without having a data sharing agreement? Because again, it does seem a little vague to me that a correctional facility is considered a HIPAA covered entity. And how would they be considered a HIPAA covered entity? And then if it's just the clinic that sits within the correctional facility, then I understand that. But how is a correctional facility considered a HIPAA covered entity? And again, referencing what Michelle said, it gets a little bit vague in there and I can't find a definitive answer.
It would be the correctional healthcare services entity that is the enrolled as the exempt from licensure clinic as a Medi-Cal provider.
So again, it's the clinic then that sits within the correctional facility or the clinic that provides treatment or medical services to the correctional facility itself.
Sorry, it's on page. I found it's on page 6, and it says for purposes of the scenarios in this toolkit, I'm going to paraphrase it a little bit. We're assuming that most of the described healthcare providers, including those who provide services through behavioral health entities and correctional facilities for any condition, are covered entities under HIPAA. And so it says including correctional facilities, but then there's a 5 footnote, and at the bottom it says, note that not all healthcare providers are HIPAA covered entities, nor are all correctional facilities in order to be covered under HIPAA, blah, 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 must submit HIPAA transactions such as claims for payment. So there's more information in that footnote, because I also didn't think it was possible that you could just say that correctional facilities are covered entities.
Well, I think like the distinction, thank you for pointing to the specific page. And this is in the draft reentry toolkit, not in the larger guidance, right?
Right.
I think is, yeah.
Yes.
So I think that there's distinction, which by the way, hasn't been publicly published. It's only been shared with the data sharing authorization guidance work group. So for everybody, all the 188 people listening in to the call, like you may not have seen the specific guidance. It's coming out in September for public comment. But I think that like basis of the question from a plan perspective is, are all correctional facilities HIPAA covered entities? I think the answer to that is no. It's to the extent that they are participating in healthcare claiming, meaning that they're an enrolled entity with the state as an exempt from licensure clinic, that then they would be covered under the as a HIPAA compliant entity. But like, I think the distinction you're making about the clinic versus the correctional facility at large, like you would be exchanging data with the correctional healthcare services entity of the county. So like if that's the sheriff's office is responsible for correctional healthcare services, then they have the clinic kind of like within the correctional facility, then that's an entity. If it's the public health department or the health department, then that would be the enrolled entity, and it would be that enrolled exempt from licensure clinic that would be the partner you would be sharing data with.
Thank you.
Okay.
I would just add, I would definitely encourage you to engage with your county councils on this topic to ensure that the way that you guys are approaching it is in line with the federal requirements as well. That's with any data sharing agreement or any of those type of situations or scenarios. We always refer you back to your county council.
Good job, Sarah. Thank you for catching that.
Understood. Thank you.
Okay, Woods L.
Hello, my name is Lawrence Woods. I'm with Santa Cruz County.
Thank you.
I apologize for the redundancy in this question if it's already been answered, but my question is, how would my county know when we'll be able to start billing? You said something about October 1st. Is that countywide in terms of all counties being able to start billing for services within the correctional facility? Because right now we're not doing that. And
so there's a readiness review process. So correctional facilities, 6 months prior to your requested go live date, will request to go live and submit a readiness application to the department for review. For October, 3 counties submitted readiness review applications: Santa Clara, Yuba, and Inyo. No other county is eligible to go live in October. We also have already received applications for the January go live date. We're still reviewing those. The next opportunity will be October 1st for a April go live. Is that right? Is that the right time frame? October for April? Yeah, I think that's right. Anybody? I think that's right. October 1st for an April 1st go live.
Okay, thank you. And then secondly is, will there be trainings provided in terms of the billing procedures, in terms of like the codes and specific codes and how that will work?
Yes, there is a billing fee-for-service billing guidance coming out imminently. There's also trainings that'll be provided in September and available through the Medi-Cal Learning Portal, and Ashley Deli put the links to the Medi-Cal learning portal in the chat. So take a look at that, sign up for the subscription service, and that way you'll get notified when trainings are live and available for the correctional facilities. I would also continue to encourage you to participate in the learning series, as we'll have more deep dives on kind of all of the different program requirements for this initiative over the course of the next couple of months.
Great, thank you so much.
You're welcome. Kate Arsenal, sorry.
Hey, no worries. So I'm from Health Plan San Mateo. I've asked this question, I think maybe a year ago, but I want to just clarify it. So we're concentrating right now on our short stayers in the jail. And if they're not losing their coverage and it's not suspended under 28 days, can the jail technically be a contractor of the health plan and bill services to the health plan for ECM for that first month that they're not suspended?
Sarah, I
So,
saw you came
yeah.
off mute. You want to take that one?
So their suspension of benefits for their Medi-Cal is only applicable to their primary Medi-Cal eligibility. It doesn't apply to justice involved, and it has no impact to whether or not someone can meet the criteria for the justice involved program. So they're kind of two separate things. So if someone has to be enrolled in Medi-Cal in order for the JI aid code to be able to be, for them to be eligible for the program and the JI aid code to be turned on. Once that is turned on, then 90-day services can be provided within that time frame. Now, I'll let OSP kind of speak to the billing piece of that you spoke to.
The special terms and conditions of our 1115 waiver require all of the billing for pre-release services to go through our fee-for-service delivery system.
Okay, got it. Thank you.
I know Sydney's been hard at work answering questions in the chat. Thank you, Sydney and the team, for the backup. If your questions are not being answered in the chat today, we are planning to publish an NFAQ document that'll get out some preliminary answers. We're also finalizing the policy guide updates, and we'll be getting that out in the next couple of weeks. And excuse me, and we'll continue to have these office hour sessions. I know we just have a few minutes left. Are there any other live questions that folks wanted to ask for today? Okay, Anna?
Hi, I put this question in the chat too, but might as well ask now. Any updates about CDCR and their go live dates?
Did somebody say something?
I can if you need me to, Autumn. But
We're working with CDCR. We do expect them to go live in early 2025, but I think we're still working with them to finalize details there.
Okay, thank you.
Heather?
I wanted to go back to the question that Kate had proposed about the 28 days. So my question, if somebody is already open to ECM, we're providing ECM services, it's May 2nd, they get picked up, they go into a correctional facility for 5 days, they get out. Obviously, they weren't less than 28 days, so they weren't suspended, their Medi-Cal wasn't interrupted. We have submitted services, ECM services, to the managed care plan. I think our question is, would we be reimbursed for those ECM services? Because while we may have talked to them, we could have talked to them while they were in custody, right? Afterwards. But we probably have also provided a service, possibly even up to the day before they went in custody, that would be an ECM service. So there wouldn't be an interruption in ECM yet, and there was not an interruption in their Medi-Cal yet. So in theory, my thought is that we would be paid for that ECM service during that 28 days because nothing had changed yet.
On the date of service, the member was not in custody. And you submitted a claim for service, even if you submitted the claim later, as long as on the date of service, like it was before they were arrested or whatever, right? Then those services would still be eligible for reimbursement. But once they're in custody, any of the services that are provided while they're in custody would be billed through our fee-for-service delivery system.
Okay.
And the JIA code would need to be active.
Would need to be
for those
activated.
to be reimbursed.
Yeah.
Okay.
Thank
And
you.
in theory, I would add they could, if the individual comes in, they confirm that they're on Medi-Cal, they confirm that they meet the criteria of the program, they can turn on that JI aid code very quickly, right? So to then allow them to be within that time frame. But there are really specific rules about billing for individuals while they're incarcerated, as long as it's not in the JI aid program or another Medi-Cal inmate eligibility program, we're not authorized to use federal dollars for Medicaid services during incarceration. So
Okay.
it's really that point of incarceration. Unless they're on JI, we cannot do anything within that frame.
Got it. Thank you.
Hey, one last question, Ron?
Yeah, mine's a quickie. Can we please have access to all this chat dialogue? There's so much rich answers and stuff, but we lose it once the meeting ends typically.
We're going to turn the like the chat dialogues into the posted FAQs so that people have
Okay.
access to it, but we're just not going to like publish, like copy and paste but
Okay.
we'll translate that into the FAQs so that folks can still have the information.
Great. Thank you.
And
You're
hi,
welcome.
I have one more question if we've got the time for it. It's a continuation of the last discussion about JI aid code activation. So in cases where a client or is actually incarcerated, however, their Medi-Cal benefits have not yet been suspended, can the JI aid code be activated so that pre-release services can be reimbursed?
Yes, as long as the individual is enrolled in Medi-Cal, regardless of that Medi-Cal being suspended, they can be enrolled
The
in
JI
the
active
program.
Great. Thank you for clarifying.
No problem.
Okay, thanks everybody. This is our first office hours. We'll keep making ourselves available to answer your questions. Thank you for coming. I hope you found the learning session last week and the office hours this week to be helpful. We'll see you again on September 5th for our next session, which will be focused on the 90-day pre-release, the pause, reset, as well as the short-term model. We're also going to have some of our county colleagues come and talk about some of the work that they've been doing to prepare for Go Live. And I think it'll be a good session. So thank you all for being here today. We appreciate you and all of the work that you're doing. Continue to send your questions to the CalAIM Justice Involved Advisory Group inbox, and we'll continue to answer your questions. Thanks, everybody. Have a great day.